Okay, you can start now.
Okay, thank you, sir. Good afternoon, everyone. Today I'm going to present the PPT on the topic. No, sorry, first I want to explain myself that I am Gauri Gupta, student of AmFarm from Japanese University, going to present my topic on design, development, and evaluation of biodesive ocular insert of timolol maleate for glaucoma and AMD treatment. Going to the second slide. This table of content contains of introductions, formulations, evaluations, plan of work, and references by the end. Going to the third slide, we have the introduction part. In the introduction part, there is the anatomy and physiology of the eye. On the right side, you can see well, the posterior part of the eye, in which it consists of conjunctiva, sclera, choroid, retina, optic nerve, retinal blood vessels, posterior chamber, anterior chamber, lens, cornea, pupil, iris, tear film, and ciliary muscles. On the left side, you can see the clear view of the cornea and the tear film. There's a two layer which consists, the upper layer consists of the tear film layers, which has lipid layer, aqueous layer, mucin layer, and by the end, which is the cornea layers, we have epithelium layer, Bowman's layer, stroma, descent member, and endothelium layer by the end. Going to the third slide, I want to explain the anatomy and physiology of the eye in brief. Three layers of the human eye we have to know. The outer region, it consists of the cornea and the sclera. The cornea reflects and transmits the lens of the light of the lens, and the retina protect the eye against infection and structural damage to the deeper parts. Going to the middle layer, it consists of iris, scalary body, and choroid. Iris control the light entering the eye and the amount of light reaching the retina. The ciliary body means the shape of the lens, which we known as biconcave and biconcave and biconcave lens. Coming to this, and this is the site of the production of the aqueous humor. And the choroid is a vascular layer that delivers nutrient and oxygen to the outer retinal layer. To the inner layers or the last layers of the eye, the innermost layer, eye layer, is the retina, which consists of rods and cone cells, and it contains the blood vessels which reach to the brain. Coming to the fourth slide, which is routes of the ocular delivery, we have three kind of dosage form in ocular. The first is liquid, and second is semi-solid, and third is solid. For the first liquid, I want to explain that the three types of liquid, the emulsions, drops, and suspension forms. And in semi-solids, we have ointments and gel. In third, we have solid, in which it consists of powders, inserts, and therapeutic contact lens. And the my part and the my version is of inserts, which is the solid in ocular dust form. Going to the next slide, I want to explain the ophthalmic insert, which is my topic and my research. In like the ophthalmic inserts, also known as ocular inserts or ocuserts, are sterile preparation. They are sterile, which is free of bacteria that prolonged residence time of drug with a controlled release of manner and negligible or less affected by nasorectal drainage. It shows diffusion control release. Third, it consists of a central reservoir of drug enclosed in specially designed microporous membrane, allowing drug to diffuse from reservoir at precisely predetermined rate. Fourth, inserts are available in different varieties depending upon their compositions and applications. Going to the next slide, we have the comparisons of ocular inserts, as we really want to know that are they good or beneficial for us or not. So coming to the merit parts, it increase the deciding time and thus improve bioavailability. Second, the side effects due to pulse dosing of conventional dosage form can be overcome by using an ocular insert. Third, provide comfort, better patient compliance, and improve the therapeutic performance of the drug. Fourth, increase shelf life compared to aqueous solution. Fifth, less to no use of preservatives reduce the risk of corneal irritations. Sixth, can target intraocular tissues via non-corneal routes. Coming to the demerits, the prominent disadvantage of ocular insert is the solid consistency, which, which patients still treat as foreign material in the eye that might develop a psychological barrier. Second, removal of the insert is difficult due to the immigration of insert to the upper fornix. Third, interference with vision. Fourth, the occasional loss during sleep or while rubbing the eye. Going to the second, next slide, we have my disease, in which I am making the ocular inserts for glaucoma. Glaucoma is a group of eye conditions that damage the optic nerve, often due to abnormally high pressure in the eye, or we can say intraocular pressure. It's one of the leading cause of blindness, especially in older adults. The most common type are open angular glaucoma, the most common form. It develops slowly and painlessly by the time or by the age. Angle closure glaucoma, second, which is it consists ocular suddenly in the medical emergency. Glaucoma often has no early symptoms, which is why regular eye exams are crucial. It left untreated, it can lead to if left untreated, it can lead to permanent vision loss. Treatment includes eye drops, medications, laser therapy, or surgery to reduce eye pressure. You can see the image impact of the glaucoma on the eye. Coming to the next slide, we have AMD, which is my second disease, age related AMD, which is also known as age related macular degenerations. It is a chronic eye disease that affects the macula, the central part of the retina responsible for the sharp central vision needed for activities like reading and driving. It is leading cause of visual loss in people over the age of 50. There are two main types: dry AMD, dry age related macular degeneration, the more common form caused by gradual thinning of the macula. Wet AMD, less common but more severe, caused by abnormal blood vessels leaking fluid or fluid blood under the retina. AMD does not cause complete blindness but can severely impact central vision. Risk factors include aging, smoking, genetics, and high BP. Coming to the next slide, we have my drug, which I'm doing the research on, which is timolol maleate. Timolol maleate is a medicine used to lower the pressure inside the eye. It, it is mostly given as eye drops to treat the glaucoma or high eye pressures. It works by reducing the amount of fluid called also known as aqueous humor and the eye makes, which helps lower the pressure. Timolol belongs to the group of the medicines called beta blockers. Even though it is used in the eye, a small amount can go to into the bloodstream. Coming to the formulation part, we have two types of methods by which we can formulate bioadhesive ocular inserts. The first is melt extrusion technique and second is self-solvent casting technique. In melt extrusion technique, the drug is the polymers passed by the through sieves in the mesh size of 60, weight and blended. Second by plasticizer is added as a mixture. Third, the blend is discharged in the melt flow rate apparatus container and extruded. Fourth, the extruded was cut into the optimum size and packed in polyethylene lining aluminum foil. They are then heated, sealed, and sterilized using gamma radiations. Coming to the solvent casting method, in this method, several batches are prepared using different proportions. The polymers is dissolved in the suitable solvent. By this, into the solution, plasticizers added as a continuous stirring. After which, the accurately weight amount of drug is added in the above solution and uniform disperse is achieved. After which, when the proper blend is formed, the solution is allowed to the cast into the petri dish using an inverted funnel to allow the slow and uniform evaporation at room temperature until the film dried. The optimum dried films are then cut into the required size and shapes using a cork borer. After which, we after which then we take the ocular insert which are prepared into and store it in a airtight containers. Uh, and then we have some evaluation tests which are important to check the bioavailability of the drug. Is first biorelease profile, adhesions, biocompatibility, comfort and mechanical properties, tolerability, safety, and efficacy. And my plan of action is to first to do the literature review or to read out how to do this thing, material selection and designs, formulation development, in vitro testing, preclinical trials, regulatory compliance. And now they are the references by the last. Thank you so much. This is my slide. By this, I want to end my slide. Thank you so much.
Thank you very much for your nice presentation.
Thank you, sir. Thank you.
Thank you.